speaking about endocrinology, do you guys have any questions from Tuesday's stuff? Do you guys remember Tuesday's stuff at all? All right, we talked about insulin a whole lot. We're going to continue talking about some other hormones that are very important when dealing with type 2 diabetics. Incretin is going to be one of the next ones. So incretin is a hormone that is normally stimulated specifically by oral intake of carbohydrates. So you can kind of look here at this graph. On the left side, you can see the plasma glucose level on the y-axis here, and then you have time. Time 0 is when the actual ingestion occurred. Looking between the white graph being, or the white line being oral glucose, and then IV intravenous glucose being the blue line here. And so you can notice the difference in how incretin is being released based on whether it's oral carbohydrates or IV dextrose. So you can see here the incretin obviously goes up much higher with oral administration. So this is going to be really important for dealing with things like satiety. Meaning, what does satiety mean? Yeah, you feel full. You don't keep eating well beyond what what you actually need as far as food goes, and so a lot of that response ends up getting blunted, especially as you have a more progressive type 2 diabetes. So incretin, and making incretin work better, or try to find something that kind of simulates the effects of incretin, can be useful for treating these type 2 diabetic patients. So the big one that incretins are kind of the overarching kind of category, but the one we'll talk about most is going to be the glucagon-like peptide 1, or GLP-1. That's going to be the most important one we're going to be talking about here. It has a fairly short half-life, around 2 minutes or so, and you see that it increases in release after meal time. So once your glucose kind of rises usually above 90 milligrams per deciliter, that's when you have increased release of this GLP-1. You'll see it being released specifically from the intestines. So that kind of makes sense why you would see release of this hormone in response to oral intake of carbohydrates versus just IV administration. But what this is going to do is it helps to stimulate glucose-dependent insulin release from the pancreas. So if you were to have higher amounts of GLP-1, that would cause more insulin to be released from the pancreas, so that's nice. It also will slow down gastric emptying time and food intake. So not only will it kind of affect satiety centrally in the CNS, but it's also going to help kind of slow things down in the GI tract. So the longer stuff stays in the stomach, the longer you're going to be feeling full for, right? So that's going to be important, because if patients are intaking less food, what is that going to do to their weight? Should decrease it, right? So we're going to see some of these drugs actually have pretty positive effects on weight, and so that's going to be important for some of our type 2 diabetics. So anyway, also you'll see that GLP-1 helps to increase transcription of insulin responsive genes and things like that. So that'll be really important. And then the metabolism of it is going to be specifically important to one class of drugs, and it's going to be done by this dipeptidyl peptidase 4, or DPP4. So that's going to be one site of action for some of our drugs here. So again, just a kind of a picture showing kind of the different actions that GLP-1 is going to have within the body, obviously in the brain, helping to promote satiety, reduces the appetite. It's also going to help to decrease glucagon secretion, increases insulin secretion. So all these things are going to be positive for our type 2 diabetics. So you guys remember those graphs previously where you see that they have way too much glucagon being released and not enough insulin for the most part, right? So these drugs are going to be very useful for helping with that. Okay. So mentioned type 2 diabetics are going to have diminished levels of insulin, already mentioned that, but they're also going to have decreased levels of GLP-1 actually being released as well. So we can do things either to help the GLP-1 that is being released to last longer. So we can do things like inhibit that dipeptidyl peptidase 4 enzyme, or DPP4, or we can actually just give exogenous incretins to try to mimic that effect without the patient having to make their own. So all these things are going to be very useful for our patients to help reduce their appetite, help increase satiety, and hopefully decrease the amount of total caloric amount that they're intaking. Which again, less carbohydrates coming in, less blood sugar being produced from that as well. So looking at insulin, also glucagon, we saw this graph previously. So you see that obviously patients with normal glucose tolerance are going to have big spikes of insulin when you have glucose intake, but you may not have that big of a spike with the type 2 diabetic, just because they're having further destruction of those beta cells. They really can't produce as much insulin as they would be otherwise. Glucagon, kind of the same thing here, where they're going to have kind of consistently high glucagon levels in a type 2 diabetic versus in a normal patient who has normal insulin resistance and normal glucose tolerance. When they ingest food, you don't really need a lot of glucagon around, so that's going to start to diminish as well. So we're trying to help to reestablish this kind of normal function for our type 2 diabetics with these incretin mimetics and DPP4 inhibitors. You can see here as well just another good graph showing you the release of GLP-1, how that's impaired for your type 2 diabetics. So this red line being the type 2 diabetics, whereas the yellow line being normal glucose tolerance. You notice that the levels are going to be much diminished as compared for your type 2 diabetics versus those that do not have diabetes. Okay. Okay, so where do we get our incretins from? Does anyone know what type of lizard this is? It's a Gila monster, right? It's on the slides. That's pretty easy. Yeah, so we actually have the Gila monster spit actually has a lot of homology to GLP-1, interestingly enough. You think evolutionarily we're probably pretty far from the Gila monster, but for whatever reason, you know, if you think about things like magic mushrooms, they're actually very similar, and the psilocybin is actually very similar to like the secretions of the bufo toad. That's why you get toad licking, right? So it's interesting the way that different products across different types of species can have homology here. But this is another good example where getting the Gila monster saliva, being able to kind of extract that, we're able to get, you know, something that's very close to the human GLP-1. And so the first one that came out in this group is Byetta or exenatide. And so this is specifically acting as an incretin mimetic, or acting to replace the incretin that your patient would normally be releasing in response to food and things like that. So normally what you're going to see patients being on it for is if they are type 2 diabetics who are, you know, they're taking metformin or sulfonylureas or other types of oral medications, and they're still really not getting their control, right? So Mitchell, what are some of our goals for, say, type 2 diabetic? So lowering the A1C, you guys remember what kind of levels you're looking for? Below 7, or if you know the more tighter controls may say less than 6.5, so that's a really good indication. What else could you be looking for?
Lower fasting. Better.
What's a good fasting glucose?
100 or less.
Around 100, yeah, so like 80 to 135. Some of those I'll be recommending that. Usually less than 180 for your postprandial glucose, right? So those are all kind of things you're going to be looking at for your type 2 diabetic patients to make sure they're actually achieving the goals you're setting out for them. So oftentimes these drugs will get added on for these patients, but again, we mentioned the weight loss aspect of this, and so you will see that some patients may be utilizing this preferentially if they do have a weight issue. So my uncle actually got put on one of these, the newer ones, come out, it's called Trulicity, or I believe it's the duraglutide, but basically he was a very overweight man, probably close to 350, 400 pounds. And I mean, like the next time I saw him, probably over a several month course, he looked like a shadow of himself, right? He had lost a ton of weight because he just really didn't feel hungry. He just didn't eat a lot of food like he used to. Which meant he cooked a lot less brisket at family events, and that was very sad for me. But anyway, very good for him though. Got a lot better control of his diabetes just because he just took a ton of that weight off. You know, he had osteoarthritis from that, so that was feeling a lot better. Like, you know, lots of benefits from being able to get the weight off. So sometimes you'll see patients kind of preferentially using these drugs for that purpose as well. Obviously, this should not be used exclusively for that purpose, although you may see some patients trying to inappropriately get a prescription for this. So there's some other kind of drawbacks to using these medications as well. But being GLP-1 being a protein, obviously we cannot give this orally. Okay, so these have to be given by subcutaneous injections, right? So if you have a patient who's already on insulin subcutaneously, this might be another injection you might have to add on board. This may be the first injections that type 2 diabetic patients may need once they're kind of transitioning from like metformin and sulfonylureas over to using one of these incretin mimetics. Okay. So you can see here that Byetta being the first one had really the shortest half-life of the group. So you're going to see a few of the other ones have much longer half-lives. You have to inject them less frequently. This one was a twice daily injection. So if you can imagine, if you're already on, you know, taking say 2 or 3 injections a day for, you know, insulin, and then you're adding on another extra 2, and again, you would not want to be mixing these. You'd have to be separate injections. It can get kind of problematic for some of your patients, you know, especially if they're very needle adverse. But these will also come in kind of pre-filled pen injectors, very similar to a lot of the other insulin-based products. So looking at trying to reestablish the normal kind of incretin flow for these patients, if you're looking at, say, a healthy control patient, so you're looking at you know, insulin levels being released in response to IV dextrose, you can see that normal kind of spike, which is what you'd expect to see for those patients. But if you're looking at patients who are receiving exenatide versus placebo, you can see they're kind of reestablishing a pretty normal amount of insulin being released. Now, we mentioned that IV dextrose isn't really the big stimulation for releasing GLP-1, but if you're already getting it exogenously, it's already kind of floating around in the systemic circulation, you will see that similar insulin response, because that's just your pancreas kind of responding to that. So you can see that, those patients who are being put on exenatide with type 2 diabetes, it looks pretty similar to what a normal healthy control patient would be releasing, right? So this is good because we're kind of reestablishing normal hormonal function, hopefully getting back to kind of a new baseline for these patients. So what are some of the adverse effects that we can expect to see? So if we're slowing down the GI tract, if we are increasing satiety, there's going to be some issues that we can see along with that. So one is nausea and vomiting. This will go away with time. Generally, it gets a little bit more tolerable, but a lot of this can be due to that decreased gastric emptying. So if they have any issues with kind of lower esophageal sphincter tone, or they're having the food sit around the stomach for longer, that can increase your chances for having nausea and vomiting. What's kind of a common kind of GI problem with type 2 diabetics due to kind of neuropathies as well? Gastroparesis, right? So it's kind of throwing up food that doesn't look like it's been digested. So that could be potentially exacerbating that, right? You may see some limited amount of hypoglycemia, not a ton of it, right? So we mentioned things, it's important to remember what drugs are going to cause hypoglycemia versus which ones won't, right? So things like insulin, will that cause hypoglycemia? Absolutely. How about sulfonylureas? Yeah, it's causing insulin to be released from the beta cells of the pancreas, right? How about metformin? No, because that's just an insulin sensitizer, so it doesn't really do anything to your blood glucose necessarily to cause hypoglycemia. So those are kind of important things to keep in mind. There's a good chart later on here that will kind of help you make that distinction here. With these drugs, you really don't see a ton of hypoglycemia. You may see some kind of synergistic effects, so if you were to have these on board with sulfonylurea. And that kind of makes sense because sulfonylureas are already kind of kicking out more insulin. This is helping you to respond better to higher blood sugars, so that may just kind of have a synergistic effect there. But generally on their own, not a ton of hypoglycemia, which is nice. Because they're slowing down gastric emptying time, you can also have delayed absorption of other oral medications, which can be problematic. Obviously, the weight loss can be a problem if it goes on for too long, right? You don't want these patients to become malnourished because they're not really eating. And then pancreatitis is kind of a unique thing that you'll see with these drugs. Okay, so again, if you're looking for unique side effects, pancreatitis is probably going to be one of these ones you see with specifically the incretin mimetics. You don't really see this with anything else in these slides. Okay, so the other ones that have been released nowadays, so there's liraglutide or Victoza, dulaglutide or Trulicity, and then the albiglutide or Tanzium. Basically, these have very similar activity, just usually you're going to have a longer half-life, so they're going to be able to be given less frequently. So for instance, you can give the dulaglutide once weekly, right? So that's going to be much preferred over exenatide, which is twice a day. Right, so that's why you're going to be seeing a lot more of these drugs necessarily than you will Byetta, which is, that was just really the first one on the market, so it was around for a good long time. I was actually at my parents' house, and I can definitely tell my father's child, because he saw a commercial for Trulicity, and he goes, "What's the antidote for that? Is it Falselicity?" Yep, that is something I would have said. Yep. Don't tell bad jokes to your patients; they'll probably go seek other providers. So anyway, so then so we have the GLP-1 mimics, we have the incretin mimetics, right? So that's that one group where we're basically kind of replacing what the patient should be releasing otherwise. These drugs, the dipeptidyl peptidase 4 inhibitors or DPP4 inhibitors, these are going to be drugs that specifically block that enzyme, and so whatever the patient is releasing, GLP-1, is going to be able to sit around for longer, right? So you're going to see that it also helps to kind of inhibit some of the breakdown of some other peptides, all of which can be kind of having some minimal effects on other kind of hormonal actions, so things like neuropeptide Y and things like that. These can also be involved in some T cell activation as well, specifically CD26. So we have a couple here that are on the market. So we have alogliptin, sitagliptin. So these are all your gliptins if you had to kind of put them down to like an easy name category. Saxagliptin and linagliptin are all the main ones in this category. So if you had to imagine which ones are going to be more potent for reducing blood sugar, the GLP-1 agonist or these DPP-4 inhibitors? I think the inhibitors. So we said how much GLP-1 is our type 2 diabetics patient releasing anyway, right? Especially with more progressive disease. Not releasing a ton of it, right? That's kind of one of the big problems. So you're typically, your incretin mimetics or your things like your Byettas and your Trulicities and things like that, those are going to be more potent because they're actually replacing what the patient should be releasing otherwise. These are going to be better for patients who are kind of a little bit earlier on, who may still have some GLP-1 that they're releasing, but you want to make that work a little bit better. Okay, so you're not really going to see as much bang for your buck out of these drugs, but what's the benefit here is the fact that they're oral medications. So these do not require injections because they're not protein-based products. They're specifically just working as inhibitors for that enzyme. Okay, so that can be one of the big decision points of whether you want to treat your patient with a DPP-4 inhibitor versus going with something like a Byetta or something, an injectable product. So keep that in mind. That could be kind of one of those decision points there. As far as adverse effects go, not a ton here, but you can see some risk for patients developing angioedema. You guys remember any other drug classes that were prone to causing angioedema? Your ACE inhibitors are big ones there. So some risk for anaphylaxis, angioedema, and then some skin rash, sometimes Stevens-Johnson's, rarely. So just looking at a study where they're actually comparing different medication regimens. So you can see here that if you were to have either sitagliptin, which is this red line here, red bar, versus metformin, and you have a couple different doses of metformin there. Obviously, bigger doses of metformin, you're going to see better effects on their change in A1C from their baseline, right? There is some kind of synergistic effects that you can see here, and this is why you'll see often that many of these drugs come as combination products. So oftentimes metformin either comes in combination with a sulfonylurea, sometimes it'll come with a DPP-4 inhibitor. Lots of different varieties that are out there in order to decrease that pill burden for your patients, so they're taking drugs less frequently, because all that will help to increase our compliance and hopefully get their blood sugar under control. Right? So again, these drugs work better. And again, looking at just, say metformin 500 milligrams twice a day, only getting maybe a 1% drop in your A1C, which you may have a patient who's got an A1C of 9 or 10, you're trying to get down. Having some synergy there is going to be better for them, right? So you can maybe get 2 points down off of that for your patients. So just looking at the differences in the two groups here, so the GLP-1 agonists versus the DPP-4 inhibitors, this is good to kind of remember the generalities that you're going to see here. So enhancing insulin secretion, yes, they're both going to do that because they're both either working as GLP-1 agonists or they're going to be helping the GLP-1 that your patient is making work better, so that's good. Reducing the amount of glucagon being released. The GLP-1 agonists are going to be a little bit more potent for that one, right? So they're going to be better at getting glucagon levels down. They're both going to help to decrease postprandial hyperglycemia, so that's good. You're going to see a lot more gastric emptying effects, and thus you're also going to see a lot better effects on satiety and appetite suppression and weight loss with the GLP-1 agonist. So usually with your DPP-4 inhibitors, you don't see a ton of weight loss associated with that. So maybe you had a patient who had their weight relatively under control, or they're doing well with lifestyle changes. That might be a patient you may want to go on the side of a DPP-4 inhibitor potentially. Also, if you had to imagine which ones are more expensive. Probably the GLPs, right? They're recombinant protein-based products that have to be injected. They're going to be way more expensive. So a question of insurance coverage is also going to come up as well. Notice that the do have some risk for things like nausea, vomiting is going to be higher with the GLP-1 agonist. We mentioned that being related back to the gastric emptying time, and also pancreatitis is the big thing you worry about with this class versus Stevens-Johnson's and allergic reactions with the DPP-4 inhibitors. For some patients, you may have antibody formation occur with the GLP-1 agonist over time that may actually either potentially lead to some allergic reactions, which are relatively rare, or you could have diminished effect of the drug, where potentially switching over to a different product may overcome that because you wouldn't have necessarily antibodies against that other product. Any question? Okay, yep. That's my goal to answer all questions before they even come up in the first place. Okay, so any questions on kind of the differences between those? Yes?
Could you give them both at the same time?
I've not seen both given at the same time. Usually if patients are not doing well with the DPP-4 inhibitors, they'll just get transitioned over to a GLP-1 agonist. Not to say that there wouldn't be any synergy there, I just really haven't seen those kind of patients, right? Of course, I don't deal with a ton of these kind of type 2 diabetics, at least in my practice, a lot, so you may find that people have different prescribing practices out there in the real world. Okay, the newest group of drugs that we're going to have here for treating type 2 diabetes, these are our sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. So these are going to be your flozins, and I have no idea how they got the names for these drugs, but they're very odd. But you have canagliflozin, you have dapagliflozin, right? You sound kind of silly saying it, and you have empagliflozin. So these are the newest group of drugs, and they're going to have kind of a pretty novel mechanism of action compared to some of our older agents here. Again, you can see combination products for these drugs available as well. What these drugs do essentially is they're going to inhibit the reuptake of sugar being filtered out through the glomerulus and the kidneys. Okay, so normally when you have sugar hitting the glomerulus, it's going to get freely filtered there, and then eventually gets reuptaken, and some portion of it comes out in the urine. So that's why you can measure glucose, especially high levels. If patients' blood glucose is very high, you can measure that in the urine, but a lot of that gets reabsorbed. So if we can block that reabsorption by giving one of these drugs, you're going to just basically pee out all the sugar, and then reduce your blood sugars to a kind of a commensurate level. This is also good for helping to reduce body weight as well. Probably not as potent as the GLP-1 agonist, but can have some moderate weight loss just due to the fact that all those carbohydrates, you're just peeing them out. You're not necessarily going to absorb them and turn them into adipose tissue. So the big adverse effect you're going to see with this one that makes it pretty unique is urinary tract fungal infections. Kind of gross, right? Because again, you're peeing out all the sugar. It's going to make it much more better kind of growth environment for things like fungus. So imagine if you have a patient who comes in, they have a UTI. That's one of those things you kind of need to scan their, because again, you're looking at type 2 diabetic patients. Are they more prone for infection or less prone? They're already more prone for infection anyway, again, because their sugar content in the urine is usually higher anyway, so UTIs can be a thing you see there. But now, you have to consider, okay, well, is this going to be a bacterial infection, which I can just treat with some Bactrim or some Caflex or Macrobid or something, or do I need to consider, something like, an antifungal, right? So then you have to consider things like, fluconazole or something like that in order to treat that. So always kind of keep that differential in your mind, especially if they have one of these drugs on board. Okay, so it's a very unique side effect with this drug specifically. May see some issues of raising the serum potassium due to some decrease in kidney function, so it could be one thing to consider, especially for some of your more heart-conscious patients. One of the kind of unique things with canagliflozin is this risk for bone fracture. They're starting to see some kind of increased bone resorption with this one, so if you have a patient who's at risk for osteoporosis or they have a previous fracture, this would be one of the drugs in this category specifically you probably want to not have, okay? And then one other thing you can see is this risk for diabetic ketoacidosis, but they would actually have a euglycemic ketoacidosis, right? So normally when you have a DKA patient, they end up having, kind of an absolute reduction of insulin, right? Because that's how they, they're not able to shuttle things like carbohydrates into the cells. They can't use them appropriately, so you start to have to go anaerobic metabolism, produce ketones and acids and all of that. So, but here, instead of getting hyperglycemic, they would just end up kind of peeing out all of the extra glucose. So that's how you can see a euglycemic DKA. Okay, so if you had a patient who had this history and they had normal blood sugar, but they're really acidotic, that would be one of the things in the mud piles you still want to kind of work up, right? The D in there being the DKA. So just keep that in mind. Okay, so I think this is a pretty good chart here to kind of guide your therapy for how you want to manage type 2 diabetic patients. Because we said for all type 1 diabetic patients, what are they going to get regardless? Insulin, right? So that's always going to be the first stop for those patients. But here, for type 2 patients, you typically want to hold off on insulin as long as you can, just because kind of once they get to that point, it's a whole lifestyle change for them. It's a lot easier just to take an oral medication than have to inject yourself. And usually they don't really get off of that unless they can really start to kind of get their lifestyle modifications in check and whatnot. So on this chart here, you're going to be seeing, and let me get the user pointer. Hopefully I did not goof up my recording. There we go. Okay, so looking here, you're going to see basically the drug that we're going to talk about, either the specific drug or the category. Then you're going to be looking at their effect on reducing the hemoglobin A1C. You're going to be looking at their risk for hypoglycemia. Then you're going to see their effects on weight, the specific side effects you'd want to worry about, and then the cost of it. Okay, so this is good to kind of guide you, and you can always kind of reference this back to this to be like, okay, what's kind of the next best step for my particular patient? So again, always want to start with metformin. It's always going to be the best drug to go with because as far as side effect profile, as far as cost goes, effect on the A1C, effect on weight gain, which is pretty minimal, this is always the first drug to go to. And again, this is working as an insulin sensitizer. So unless they have, what would be one reason you would not want to use metformin? They already have. Well, they have a lactic acidosis. You probably wouldn't want to initiate metformin. That might be bad for them, right? What type of organ dysfunction would I not want to start? This patient. Kidney dysfunction. There you go. Yeah, you kind of had like two options. You're like, oh, liver or kidney, okay. Liver dysfunction, kidney dysfunction is the thing you want to watch out for. Remember, if the creatinine clearance is less than 30, you do not want to start metformin because they're more likely to kind of build up levels of that, and they're going to develop that lactic acidosis, or at least have a higher risk for that. So watch out for renal dysfunction with metformin. Okay, but other than that, it's a great drug to start most of your patients off with. The biggest adverse effects you're worried about is going to be really just GI in nature. You can get around that sometimes by using either extended release preparations or kind of adjusting your dose to where they can kind of tolerate it best. Okay, but certainly the worst cases of metformin I've seen, at least from a toxicology standpoint, are those kind of little old ladies who had poor kidney function that no one was really kind of checking over a period of time. They get dehydrated, and then all of a sudden they come with this like just horrible lactic acidosis, and usually they end up having to get around to dialysis in order to help kind of pull all that off. It doesn't do anything to get rid of the metformin, but it helps to kind of reestablish a normal pH for them. So be careful with that in that kind of at-risk patient group. Okay, so you get them on metformin, you try that for a period of time and see how their A1C responds. You know, normally A1C is going to take a little bit longer to respond because it takes about how long? 3 months, right? Because the A1C is kind of over that lifespan of the red blood cells, so it takes about 3 months or so for your kind of A1C to really kind of kind of get back into a new kind of homeostasis. But you can look at things like what's their fasting blood glucose, what is their postprandial blood glucose. So hopefully they're doing those checks as well to kind of see what kind of effects you're going to have with your new drug therapy. So once you are not reaching your target A1C, what can you add after that? Well, you have lots of options, right? So you're going to be making it more kind of patient dependent on kind of what's their background, what other comorbidities do they have, what are the things that we need to, what's important to our patients. So this is where you can start to make some different decisions. Traditionally, before a lot of the newer classes of drugs came out, it was usually sulfonylureas. That was usually the next step you went on there. But remember, has good effects to reduce A1C because we're causing the beta cells in the pancreas to release more insulin. But you're also going to see a moderate risk for hypoglycemia. Right? Very little effect of hypoglycemia with metformin, very little risk there. Sulfonylureas certainly are going to have that potential problem. Certainly you're going to see weight gain because anything increasing insulin concentrations can cause weight gain. Okay. And then, of course, hypoglycemia just really being the biggest risk there, but also very low cost. So that's kind of the benefit there. It's very, very cheap. You can find easy metformin, sulfonylurea combination products to give to your patients. So that's usually the next easiest step to do. Of course, you can look at things like adding your TZDs, right? So you guys remember how those worked? So they kind of increase the insulin responsive gene transcription by affecting that PPAR gamma receptor, right? So the TZDs or thiazolidinediones, those are going to be working to kind of increase a lot of those kind of, also working as an insulin sensitizer essentially, right? So less hepatic glucose production, more uptake in the skeletal tissue, things like that. Obviously, the biggest risk we're worried about is going to be for our CHF patients. Remember that we saw, especially with the rosiglitazone, you saw increased risk for things like cardiovascular death. So probably pioglitazone is a better one to go with that. Usually, you're not going to see a ton of weight gain associated with it. You may see a little bit. And then as far as cost goes, it's going to be more on kind of the moderate side, right? So patient with CHF, probably not the best choice for them necessarily, but it could be another kind of good adjunctive medication otherwise. And then you can look at things like your DPP-4 inhibitors. Obviously not going to be nearly as much bang for your buck as you would see with like the GLP-1 receptor agonists, but also they don't have to inject themselves. So that could be one thing you're looking at. Cost is obviously going to be higher than you would see for some of the other ones like the sulfonylureas, so be aware of that. Looking at the SGLT2 inhibitors, really the things like genitourinary infections are going to be the big risk there. Some moderate dehydration, but really just education is good on that one. So just kind of tell them to make sure they're staying well hydrated, and hopefully they can avoid that problem. And then insulin's obviously going to have be the biggest change for those patients, the biggest risk for hypoglycemia, more risk for weight gain, all that kind of things. But again, if they're really not hitting their goals, this may be the next step. But of course, if they get on kind of dual therapy and they're really still not hitting their goals, this is where you can try to do triple therapy. Here you can see where you're just kind of adding on just another drug to the combination, but this is usually the place where you're starting to consider whether or not we just need to go to insulin, right? Because insulin is going to fix their problem, just no matter how much you need to give in order to help kind of replace what they would normally be releasing otherwise. But you always want to make sure you're keeping on your insulin sensitizers if you have insulin on board as well, okay? That's only going to make your patients insulin work better for them if they're on that. So you usually are going to keep them on metformin. They'll usually also be on like on like a DPP-4 inhibitor or a TZD or something like that in order to help kind of increase that sensitization to that insulin. Okay, so because you can certainly give enough insulin to overcome those doses, but anything we can do to spare the insulin dose and try to keep that as low as possible is going to be better for our patients. Okay. Usually for those patients getting started on insulin, it's usually going to be kind of a long-acting drug to kind of help replace that basal amount of insulin. But if they have especially problems with kind of postprandial glucose uptake, then you may have to do mealtime insulin as well. Okay. Any questions on that? You guys are all diabetes experts, right? Try to kind of hit up your diabetes educators. Those are going to be really good people to talk to and try to get more information about, okay, what do you see out there? What are a lot of your endocrinologists doing? What's their kind of their usual steps? Because everyone's going to be a little bit different. Obviously, depending on what their experience is or what their patient population is like, they may have different ways they're going to go about this, right? So if you're dealing with more of a kind of more of an indigent population, they may not be able to afford a lot of these expensive injectable medications. They may say, okay, metformin and sulfonylurea is for everyone, right? Or if you're dealing with patients who have better insurance coverage, maybe using a GLP-1 receptor agonist is going to be better for that patient population. So kind of get a feel for kind of what their processes are and what they normally do. Okay. So any questions on diabetes in general? So you may see some patients, especially on the inpatient side, some patients who might not have been on insulin outside of the hospital, they may get put on sliding scale insulin regimen. Sometimes you'll see that because being hyperglycemic for prolonged periods of time can increase inflammation, increase risk for infections and things like that. So sometimes, especially in ICUs, you may have patients who are being put on insulin drips in order to help control their blood glucose. And sometimes they'll be put on sliding scales, especially if you're having to take them off of their other diabetic medications. But beware, you may see that for a patient who's otherwise not on insulin, they may be put on that for the duration of their hospital stay. Usually on a sliding scale versus as a carb counting thing like you'd see like a type 1 diabetic. All right, moving on then. Next, we're going to talk about kind of a smattering of different endocrine conditions, ending up with thyroid hormone at the very end. If we finish up early, then I will start off with the next section, so you can download that if you need to. But first off, we're going to talk about hyperprolactinemia, only specifically because we have certain drugs to treat this with. Usually you're going to see this occur when you have prolactin secreting tumors, but there can be some other cases where this can happen as well. So if you guys remember back to your behavioral section, anytime you block dopamine 2 receptors, you increase the amount of prolactin being released as well, right? So that's why you worry about, especially with your first generation antipsychotics, you did see a lot of things that were related to high levels of prolactin. So you saw things like galactorrhea, you saw things like infertility potentially. So that's all related back to that dopamine 2 antagonism causing increased amounts of prolactin. So as you might imagine, the drugs that we're going to use here are going to be dopamine agonists in order to help kind of reestablish that balance and decrease prolactin levels. So if you think about that kind of mechanism there, that's going to work a little bit easier to keep the drugs you would use to treat this in mind. But anyway, the way we're going to do this is with our ergot alkaloids. Where else have we seen ergot alkaloids? Yeah, migraine, right? We use dihydroergotamine to treat those migraines. So as you might imagine, what do those do to the blood vessels? They constrict. So there's also going to be some side effects you're worried about anytime you're given these kind of ergot-derived drugs. But two we have here is going to be bromocriptine, parlodel, or we have cabergoline. Bromocriptine is probably the older out of the two, but obviously you're watching for things like dizziness, fatigue, headache, nausea. All that can be related back to the dopamine 2 or just the dopamine agonist effects there. Again, anytime we said we're given DHEs, it can cause a lot of nausea, vomiting. So the same thing can be seen here as well. Sometimes you'll see this being used to help induce ovulation for patients who have a history of hyperprolactinemia. So sometimes you'll see it being used for that specifically. You guys know anywhere else you might see bromocriptine being used? Maybe like emergent condition? Sometimes for neuroleptic malignant syndrome. You guys remember that possibility you can run into with your first generation high potency dopamine 2 receptor antagonist. You can sometimes see neuroleptic malignant syndrome. Theoretically, by giving a dopamine agonist like bromocriptine, you can reverse that effect. Clinically, I don't know how often it gets used, but that may be one other case you see being used out there. So not super common, you see that one. But cabergoline is going to have a higher affinity, so it's going to have higher blood pressure effects. So you can monitor their blood pressure and make sure it's not getting too elevated. Okay, next we'll talk about the androgens. We figure, the ladies got their time when talking about the OB-GYN stuff. Now it's time for the guys to shine, right? You guys are all experts on testosterone already, right? I see lots of beards, so yes, I'm going to assume yes, you guys are experts. Okay, this is as far as I can get before I start to look like a homeless man, so I'll be shaving tomorrow. Anyway, so the natural production of a lot of these steroids, there's a lot of kind of interplay between the different formulations, and so keep this in mind with the different types of enzyme inhibitors we're going to be looking at, because there's a lot of kind of interplay here. So you have things like, cholesterol, obviously that being kind of the starting point for a lot of these hormones, eventually getting converted into things. Let me get my pen out. So it gets kind of converted to this kind of precursor to pregnenolone, but you can see it being turned into things like cortisol, right? So that's really important for, we'll talk about that a little bit later, but important for things like, adrenal function, right? You're going to see it being turned into progesterone, which we talked about extensively in the OB-GYN section, but you can also see it being converted over straight to testosterone, okay? And then, but it's always important to remember that testosterone eventually can be converted over into estradiol. So that can be one of the things we're looking at, where if you were to have things like, too much estrogen activity, you can inhibit that by, inhibiting this enzyme process here, but then you always have to worry about having too much testosterone effect, right? So it's kind of a delicate balance here between how these drugs get metabolized into the various other types of hormones. Aldosterone is really important here. What does aldosterone do for us? Yeah, regulates blood pressure, right? Because it has those mineralocorticoid effects, right? So those are things that help to increase salt and water retention, help maintain blood pressure. We're going to talk about other drugs that have high mineralocorticoid effects a little bit later as well when we get to the adrenal section. So just kind of keep all those facts in mind. But we know that testosterone is going to be the most important androgen. It's made in the testes. Is it the most potent androgen that we make? I'm asking the question, so probably not, right? So there's actually a more potent form. So there's an enzyme called 5-alpha reductase that is going to convert testosterone over into DHT, or dihydrotestosterone, okay? That is actually going to be the more potent androgen within the body, but it's not really the one that gets directly made within the testes itself. But it'll be important because if we're having too much androgen activity, one of the things we can actually do is inhibit that enzyme, that 5-alpha reductase, right? You guys, actually, we'll talk about that more in the urology section, but this will come again when we talk about BPH specifically, or benign prostatic hyperplasia. But anyway, again, any of the testosterone that we're making can be a small amount of it will be converted over to estradiol by the enzyme aromatase. You guys remember where we saw aromatase being used previously? Yeah, breast cancer, right? So it's kind of refractory breast cancer where you want to try to limit as much estrogen production as possible. Aromatase can be useful for this. But then, what type of side effects do you think you'd expect to see from that? You see more androgen effects, right? So you can see things like lower voice or have hirsutism, things like that, that can occur from having kind of too much testosterone around in those female patients. But similar to things like estrogen, it is metabolized within the liver, so we can expect to see some liver effects from this. So we'll have some effects on things like cholesterol and whatnot. And essentially, the mechanism is very similar to all other hormones. It's basically going to get into the intracellular space, go down to the nucleus, and influence gene transcription. So making new proteins or shutting down protein production based on the type of receptors it's interacting with, depending on the tissues we're at. So this will look very, very similar to what we saw in the OB-GYN section. We were talking about kind of ovulation and the normal menstrual cycle. But again, remember your negative feedback loops that are happening here. And this will be important when talking about things that, like, if we need to completely shut off the production of testosterone, like, how can we do that? And a lot of it goes back to how can we affect these negative feedback loops, right? So essentially, all of it's going to start back up in the hypothalamus here. We have GnRH. Anyone know what that stands for? Gonadotropin releasing hormone, right? So that's going to have a positive effect here on the pituitary gland, and that's going to be a releasing luteinizing hormone and follicle stimulating hormone. You thought it may have only been for ladies, but it's not, right? So guys have that as well, and that's going to help have positive effects to stimulate the testes, and that will have sperm production, have testosterone production, and that's where they get the negative feedback loop happening here, where testosterone can eventually feed back and cause LH and FSH production to decrease, or it can affect GnRH as well. Okay. Eventually, you can also have too much GnRH, or have some products that act specifically like GnRH in order to help inhibit the hypothalamus as well, to basically kind of shut the process off even higher up in the cascade here. So we have a couple of different varieties of testosterone that we can administer for our patients. So we have the naturally occurring testosterone. So we have just regular testosterone that you can administer, and you also have dihydrotestosterone. Now you'll notice here that most of these are not going to be given orally. We'll talk about the problems with orally administered androgens in just a bit, but for the most part, these are either going to be given as a transdermal product. Sometimes you'll see patches. Sometimes you'll see gels being used, lotions or creams and things like that. You will also have injections being done as well. Okay, so usually like intramuscular injections of testosterone products. Yeah, so these are just like a lot of different brand names you're going to run into. So there's lots of different products that are out there. Just be aware that that's usually the dosage forms that we're going to be giving is either injectable products or transdermal products. Okay, because we'll talk about the oral problems in just a minute. And then most of that testosterone gets converted over to DHT by that 5-alpha reductase, unless you were to have like an enzyme inhibitor on board, which we'll talk more about a little bit later. There are some synthetic forms that you can potentially give. So you have things like methyl testosterone. See some names here. Notice these are PO formulations, right? So they're going to have some side effects associated with those. We have things like fluoxymesterone, oxandrolone. All these can be given by the PO route. They've been kind of monkeyed with in their chemical structure to make it a little bit more bioavailable, a little bit easier to administer from that standpoint. But for the most part, especially for patients who have just kind of a deficiency in testosterone levels, usually just natural testosterone is going to be given as a supplement, right? So looking at the different effects we can have in the tissues, so looking at androgen receptor-mediated effects, testosterone itself is going to have positive effects on things like the internal genitalia production. That's when we see like puberty and whatnot. Skeletal muscle cause growth of skeletal muscle. Erythropoiesis can have positive effects on that as well, to increase blood cell production. And then with DHT, this is where we see things like production of the external genitalia and also the hair follicles. So typically guys that have higher amounts of testosterone, they have higher amounts of DHT. What does that usually lead to? Balding, yeah. So actually you can end up seeing some male pattern baldness happen related back to DHT, right? So keep that in mind. But you can also, when we have the testosterone being converted over to estrogen by aromatase, this is where it can have effects on the bone, especially on the this is where we worry about too much androgen, supplementation early on. You can have kind of premature closure of the epiphyseal plates. You can also have issues with libido as well. Okay. So what are the uses for our androgens? We'll also look at some anti-androgens that we can use as well. So usually for male infertility, we can use things like testosterone or methyl testosterone. Those are going to be your other products we mentioned before that have been kind of altered to allow for kind of oral administration. But also if you had a patient who's had, say like testicular cancer or something that had those removed, you can give exogenous testosterone to help kind of replace production of that. So it's another common place you'll see that. Testosterone will have positive effects on the bone, so it'll help for especially high-risk patients for osteoporosis. It's going to have some benefits there. And then sometimes you'll see it used in hormone replacement therapy in combination with estrogens. Not super common, but you may see it used there. Mentioned fluoxymesterone can be used for inoperable breast cancer. And then sometimes you'll see these drugs being used for patients who have like wasting syndromes or malnourished, things like that, to help kind of work as an anabolic hormone to help increase muscle production and put on body weight. So you got a patient who have like something like burns or trauma, late stage AIDS, COPD, things like that, where they're basically just not able to really keep on enough muscle mass and body mass. Like this can be useful for doing that. And then you'll see our anti-androgen products, which we'll talk about a little bit later, are used typically for metastatic prostate cancer and if, potentially for things like hirsutism in females. Okay, so the oral formulations we mentioned here, the testosterone itself gets metabolized in the liver, so that increases your risk for a lot of hepatic side effects you see with that, but by changing the formulations, making those methyl testosterones or these 17-alkylated testosterones, that allows for easier absorption of it. So those products can be given by the PO route, but usually not the most common ones you're going to see being used. Usually the injectable products or the transdermal products are most often used. A lot of the injectable ones are going to be kind of in an oil-based emulsion, so that way they actually have very long-acting effects. So if you see like the depot testosterone, they'll have kind of several months effects versus having to be injected like every day. But your transdermal products, typically, especially the gels and things like that, would have to be administered at least once a day, sometimes more frequently depending on what type of replacement they need. So here are some of the androgen receptor antagonists we're going to run into. So things like flutamide, bicalutamide. Again, those are going to be useful for things like prostate cancer when you want to inhibit the growth of those cells. We'll talk more about that when we get to the urology section. But testosterone and DHT have very positive effects on growing prostatic tissue. So if you had especially metastatic disease kind of spreading throughout the body, you want to inhibit that effect as much as you can. We have drugs that have some mixed activity. So you have to have things like spironolactone. You guys remember where we used that previously?
Diuretic.
As a diuretic. It's good for like heart failure. Yeah, CHF is one of the places. So you might see it being used for CHF patients. But one of the side effects you worried about was what? Gynecomastia, and a lot of it has to do with that anti-androgen receptor activity. So you saw some kind of increased estrogen type of effects because you're antagonizing those androgen receptors. So that's one of the things you saw there. You have things like, and then we'll talk about our 5-alpha reductase inhibitors specifically. These are good for blocking conversion of testosterone to the DHT. So finasteride, dutasteride, those are going to be used very frequently for treatment of BPH. We'll see those a little bit later. So look at the side effects of when we give exogenous testosterone. What is going to happen? What is going to happen when we do this? You can see prostatic enlargement, potentially worsening of prostate cancer if that has maybe been previously undiagnosed. So be concerned with that. Why do you think you get testicular atrophy? Exactly, yeah. So anytime you're giving exogenous testosterone, you're causing that negative feedback loop to be activated. You're going to be producing less of your own testosterone, so you're going to see atrophy of that tissue there. Gynecomastia and acne can happen as well. Gynecomastia being more from the conversion of testosterone over to the estrogen products, so that can be problematic. Acne as well, just because you can see increased sebum production and things like that. So you guys ever seen those like big bodybuilders have like really bad acne? That could be one of the side effects, right? Maybe if you just go to like a Gold's Gym, you'll see it. Also, due to some of the mineralocorticoid effects, you can see increased sodium and water retention, so that can be problematic for patients like CHF. Watch out for that. And then we mentioned those the hepatic effects as well. So you mostly with the 17 alkylated androgens, you're going to be seeing things like cholestasis that can occur. So kind of similar to what you saw with your estrogens, but also reduced HDLs, negative effects on your lipid panel, and then possibly some hepatitis. So this is kind of the big problem with oral administration. This is why we typically avoid it whenever possible. And then you can also see this masculinization in females. Typically, you're going to see that some of these effects are not necessarily going to be reversible. So some of the hirsutism, some of the the voice lowering, things like that may not be totally reversible for your female patients. So this is why it's typically avoided in most of them. So some of the hormonal therapies you're going to see used for treating things like BPH, using our dihydrotestosterone inhibitors, basically by blocking the action of 5-alpha reductase, you lower levels of the DHT, you have less kind of pronounced effects on the prostate. We're going to see this more in the urology section, as I mentioned, but finasteride and dutasteride are the two main drugs here. We'll talk more about those in detail later. And then a couple other drugs you can use. These are GnRH analogs. These are used specifically, basically, to kind of shut down the whole process here. So by increasing activity, because even though these are agonists at the GnRH receptors, these eventually going to shut down that whole pathway. So you have less GnRH being produced, you're going to have less LH and FSH being produced, and less testosterone being produced eventually. And so these are goserelin and leuprolide are the two big ones you can see being used here. Okay, we'll talk about some uses for those a little bit later. So again, this is kind of a helpful picture to kind of showing you where some of the different drugs are going to be working at specifically to inhibit this process. So you can see things like androgen receptor antagonists, like flutamide and bicalutamide being used down there. Things like finasteride inhibiting that production from testosterone to DHT. So you can kind of go back and kind of see where the different steps in the process are being inhibited by the different drugs we talked about. Any questions on what we've talked about previously? Guys feeling a bit more manly and no? Nothing? Okay, too early. All right. So talking about corticosteroids, we've mentioned these drugs pretty extensively. What are some good examples of corticosteroids we use? Prednisone's a good one. Dexamethasone. Methylprednisolone. Good. So do those have high mineralocorticoid effects or high glucocorticoid effects? Glucocorticoid effects, right? So glucocorticoids are good for dealing with inflammation. We're going to be talking about more specifically here dealing with things like cortisol, which are going to have more of a mineralocorticoid effect. And dealing with the mineralocorticoids, we're going to be seeing things like blood pressure regulation. This is going to help to maintain intravascular volume. This is why it's really important in cases where you have like sepsis and kind of systemic hypotension related to infection. We'll talk more about that, but looking at things like the mineralocorticoid receptor, kind of the prototypical thing that activates that is also aldosterone, has good positive effects there. So it's going to be important for retaining sodium, retaining water, and keeping the intravascular space full to maintain that blood pressure, right? Also can deal with, work at the level of the kidney and also help regulate blood volume from there as well. The main drug that we give that has good mineralocorticoid effects will be hydrocortisone, right? Which is basically just cortisol that our adrenal glands would normally be releasing anyway. So normally cortisol has kind of a circadian release to it. What does that mean? It'll kind of vacillate throughout the day, right? So depending on whether it's nighttime or daytime, you may see some changes in the actual amount being released, but it basically will not be just kind of a standard basal amount that your adrenal glands are sending out. But when you ever have things like acute stresses, you will see increased production of cortisol to help deal with that, right? So typically when you have patients who are like really stressed out, what happens to their weight usually? Usually goes up, right? Because they have more cortisol, they're having more water retention. That's usually one of those things you can see along with that. It's one reason why you may see that. It could also be some stress eating and stuff involved, but this is one possible mechanism here. But what happens when you have insufficiency of cortisol? So you can have Addison's disease, which is kind of the chronic deficiency here. A lot of weakness, fatigue, weight loss, hypotension associated with this. Also some inability to really maintain their blood glucose. What do the glucocorticoids typically do to your blood sugar?
Increase it.
Should increase it, right? So again, if you don't have enough, steroid effect around, you may have problems maintaining that glucose appropriately. And again, it's not just black and white. You don't have just glucocorticoids and just mineralocorticoids. It's more of a spectrum with how much activity they have at either receptor, right? So things like fludrocortisone is almost exclusively mineralocorticoid. Hydrocortisone is going to be kind of more on the gray side there, but maybe a little bit more on the mineralocorticoid side. But essentially, what we can do for those patients, especially when they have really major events, like stressful events, which normally your body would respond by increasing, cortisol release, and they can't do that. You can see things like circulatory shock and death related to that. We see this probably most commonly in pediatric patients for those who have had like a pituitary adenoma that have had that resected. They have a lot of issues releasing, normal kind of trophic hormones that help to regulate the adrenal cortisol release and things like that. And so they oftentimes have to be put on exogenous steroids in order to maintain their blood pressure, right? And so very frequently when they get stressed out, they come in hypotensive, very tachycardic, and we have to give them stress dose steroids in order to help replace what they would have produced otherwise. Okay, so that'll be one of those things where patients will have, 3 times daily hydrocortisone that they take, and if they know they're getting sick or if they're really stressed out, they will have a stress dose that they're going to take in addition to that in order to help kind of supplement what their normal, adrenal glands would be sending out anyway. Okay, does that make sense? Okay. So again, typically they'll give anywhere between 20 and 30 milligrams of hydrocortisone a day. This is orally. Again, because we want systemic effect. Normally when we're giving hydrocortisone, it's as a topical preparation. You don't see a ton of systemic effects there, but here we're using orally. Potentially if they're coming into like the hospital setting, you may use IV as well. That can be used there. And then you also want to use it with a salt-retaining hormone as well. So fludrocortisone is going to be a big one here. Fiorinef is the brand name if you ever see that. That is used very frequently to help maintain that intravascular volume as well. Really long-acting, non-salt retaining glucocorticoids should not be used here. So things like dexamethasone, prednisone are not really going to be good for this type of replacement, right? So hydrocortisone, fludrocortisone are your 2 big drugs you're going to see being used here. This is also why frequently when you have patients who are, say, they're septic, coming into the emergency department, getting ready to go to the ICU, if you're having a lot of problems maintaining their blood pressure, because typically what happens to the intravascular volume when you have a septic patient? Usually diminish, right? They're very leaky capillaries, they're third spacing a lot of fluids, and so you're trying to replace that by giving a ton of fluids, but if the vessels are not really tight, right, those gaps are too large and they're letting all the fluid out, you can't really maintain their blood pressure well. You can give them norepinephrine, you give them epinephrine to try to increase their pressure, but nothing's really working. Very frequently they'll do stress dose steroids there as well, give them a couple of doses of hydrocortisone, all of a sudden you see their blood pressure come back up and you can get them off most of their pressors. So you may see that being used sometimes in like your ICU type patients when they're really critically ill. So, any questions on that? Yes, sir.
Why do we see hyperpigmentation with Addison's disease?
That I don't know the actual mechanism for.
Okay.
Maybe it has to do with that. Very quick, up-to-date search wouldn't be able to enlighten us, but I don't know off the top of my head. Anyway, so we'll finish up with some talk on the thyroid pharmacology, since we have some good drugs that you can use both to help stimulate the thyroid function in the body and also to inhibit it as well. So a couple of different problems that you can run into with thyroid regulation within the body. Hyposecretion can either be kind of a couple different levels it could be occurring at, so this will be important with deciding how we're going to necessarily treat this. It could be primary, where, say, for instance, you have destruction of the gland, or if you have lack of precursors, which you guys know what a good precursor is for thyroid hormone? What metal? Yeah, iodine is going to be really important here. So if you have lack of precursor, you may have hyposecretion due to just not being able to produce the actual thyroid hormone. It could be issues if you don't have the actual trophic hormone being released from the pituitary or from the hypothalamus level. So again, most of the time we're going to see hyposecretion of thyroid hormone being replaced with just giving a hormone replacement, right? So that's usually pretty easy, the easiest thing in order to help treat this. So for instance, if you were to have an issue to where you're having thyroid hormone deficiency, what does your TSH, or thyroid stimulating hormone levels look like? Are they high or low? Yeah, usually high, right? So they're going to be high because they're trying to help to stimulate the thyroid gland, but it's not really doing anything. So that could be a sign of, like, a primary hypothyroid issue, things like that. So you can look for different lab tests, but essentially what we're going to be doing to treat this is just to replace by giving exogenous thyroid hormone. Okay. You can also have hypersecretion issues. So again, it could be a primary, secondary, tertiary issue, but essentially we're all going to use the same drugs for this as well. We want to block actual production of the thyroid hormone, but you're going to see this takes time. Really, thyroid treatment takes time in general because it's not a quick process. Bless you. The solid sneeze, yeah. Okay, so anyway, so again, looking at a picture, again, very similar to what we've have seen previously, both androgens, both estrogens. Again, the pituitary is being signaled by the hypothalamus, which is then going to go down and signal the thyroid gland with the TSH. That's why those levels are increased when you have hyposecretion of thyroid hormone, because the negative feedback loop is not really being activated here, right? And so notice we have T4 and T3 here. Which one is the more active form? Yeah, T3 is going to be the more active form. So we'll look at that, and that's going to be important with some of the different medications we can give. They might have different formulations of whether they're T4 or T3 or a mix of the two. But we naturally have both circulating within the bloodstream. Okay, so what is the process for actually producing thyroid hormone? I'll kind of walk you guys through. Have you guys seen something similar to this before? Maybe not so much. Okay, we'll talk about this in more detail. But basically, you're going to have iodide coming into these kind of apical cells of the thyroid gland, right? So they're going to be coming into these cells, and they basically this iodination occurs where this peroxidase enzyme turns it over into iodide, right? This iodine to iodide. The slides will prove me wrong in just a second here, but anyway, basically you have the conversion of the iodine here, and it's going to get this organification process essentially, right? So tyrosine gets involved here. Thyroglobulin is going to also be helping to this process to occur, but essentially what you're going to end up getting is either monoiodotyrosine or diiodotyrosine. Okay, so basically tyrosine gets added onto the iodide gets added onto the tyrosine either once or twice. Okay, that's going to be important because that'll either produce T4 or T3. So we'll show you a couple slides what that looks like in just a second. Eventually, it's going to come back into the cell here. It's going to get that thyroglobulin removed by this proteolysis process. It's going to get taken off there, and then it can be released into the bloodstream. Okay. Here you're going to have usually higher levels of T4 to T3 being circulated around, but eventually T4 gets converted over into T3, where it's going to have its active effect. Okay. Obviously, there's some things we can do to inhibit this process. We're going to look at some different drugs that we can use to do that. What do you call it when you have too much thyroid function happening? It was like when it was really severe. Yeah, thyroid storm is yeah. So you have thyroid toxicosis and then thyroid storm, which is really kind of how would you describe thyroid storm? Some altered mental status. What else? What does their blood pressure and heart rate look like? Usually elevated. Usually they're sweating, right? So you'll see there's some drugs we can use to help kind of immediately block those effects. But again, dealing with anything with the thyroid, it takes time because this process is not really quick. Okay, so we'll talk about some of the different ways we can do that in just a minute. Okay, so this slides will basically kind of going over what we just talked about. So basically you have the iodide trapping. Sorry, it goes iodide to iodine. Again, I'm not going to ask you that on a test, so don't worry about that specifically. But just realize that while iodide is necessary for this process, if you have too much iodide around, that can actually inhibit this. Okay, so you can see some cases where we're going to use hypersaturated iodide solutions to basically just kind of overwhelm the thyroid gland and shut down thyroid hormone production. Okay, so too little is bad. Because again, if you have too little iodine, what does that kind of manifest as? Well, yeah, so you get the big goiters, right? So that's kind of one of the big causes for, especially in like developing countries and things like that, where they have iodide deficiencies. They usually get those kind of big goiters associated with that. So too little iodide is bad. You're not going to make any thyroid hormone. Too much can also be an issue as well. Okay, so we'll talk about some different cases of that. But so anyway, once that process occurs, then you're going to either form that monoiodotyrosine or the diiodotyrosine, and two molecules of those can kind of come together to form either T4 or T3. So I'll show you that in just a minute. So once the molecules kind of come together, if you have two molecules of diiodotyrosine come together, that's T4. Okay. If you just have a monoiodotyrosine plus a diiodo, you get T3 out of that. And again, we said that's the active form. Sometimes you get this kind of reverse T3 that can be made, which is not going to be active, but eventually it gets released into the bloodstream where it can have its mechanism of action. The usual ratio of T4 to T3 is usually about 5 to 1. Okay, T3 being the more active form, but it's going to be in smaller amounts than T4 normally is. So again, just kind of going to this picture, we already talked about this, so I don't belabor the point. But anyway, once the thyroid hormone kind of comes back across, it can be relieved of that thyroglobulin, that proteolysis step we talked about, and then released out into the circulation. So so I mentioned when you have that deiodination that occurs out in the bloodstream, basically you're going to be removing one of those iodine groups to be making T3. Some of it will be this reverse T3, which is not active, and that will just end up getting metabolized out. But T3 is the main form we want to be looking at for our active thyroid hormone. So kind of see here, this would be a diiodotyrosine, or T4, right? So that kind of makes sense if you look at that. So both of these molecules were tyrosine originally. They both have two molecules of iodide associated with them. Once they get that deiodination occurring, they're either going to be removing the right iodine here to make T3, or you can have this reverse T3 that gets made. Basically, the wrong one gets taken off, and it can eventually just get eliminated. Okay, but this is the one we're actually interested in, this regular T3. Okay, so how can we replace this? So we can just basically give exogenous either T4 or T3 or some mixture of the two. So the most common one we're going to see being used here is going to be levothyroxine, which is T4. Okay, very frequently the brand name we use for this is Synthroid. So you may see that. It's available either orally, which is the most often given, or in some cases you may actually see IV Synthroid being used. We'll sometimes use that for organ procurement. So if you have a patient who's going to be an organ donor who's been declared brain dead, a lot of their endocrine functions kind of go haywire, and so we end up having to replace a lot of things like giving them insulin, giving them vasopressin, giving them thyroid hormone as well, but we give them IV levothyroxine in this case. Basically, you will have the drug being absorbed, kind of has variable absorption, but because it takes so long for the drug to really get at a good steady state and for it to be converted to T3, it doesn't really matter so much as long as they're taking it consistently. But it will eventually get converted over to T3 once it's in the natural body. It's important to note that you'll have lots of drug-food interactions with this, so you can have lots of things binding it up. So iron, calcium, aluminum can all bind up your thyroid hormone and prevent it from being absorbed into the GI tract. Okay, so be aware of that one. And then also anything that are inducing hepatic P450 enzymes like CYP3A4 can also increase elimination of this as well, and lead to lower T3 levels in the bloodstream. Okay. Because this process takes a long time to occur, for instance, if I had a patient who called me up at like the poison center and said, hey, my kid accidentally got into my Synthroid and took a whole ton of it. One of the things that they have to realize is that you're not going to really see clinical effects from this immediately. It takes about a week for it to actually be converted over into the active T3 form. So this is one of those things where I'm actually like, okay, let me go ahead and schedule a call back in about a week or so to see how the patient's doing. Most of the time they don't really get enough to be a problem, but it's important to know if you ever have like an overdose of levothyroxine, it's not going to be a problem initially. A week from now they could be having thyroid toxicosis and hypertension and sweating and ultramental status, but immediately it's not going to do anything. So this is why you have to wait so long between checking TSH levels and things like that to make sure to see where it's actually going to be re-equilibrating to. There is the active form, which is liothyronine or T30. Some patients will end up being put on this for whatever reasons. I'm not really sure. This would have a faster onset to action. So it's also going to be more expensive, not used as frequently. But it also is going to require more frequent dosing. So again, the half-life is not nearly as long as you would see with just giving something like levothyroxine. But that could be one other product you see being given there occasionally. And then you have Liotrix, which is trying to mimic what the body is naturally producing anyway. So you can see it's a kind of a 4-to-1 ratio of T4 to T3. Thyrolar is the brand name for that one. Again, I don't really see this one being given ever. Most patients just get put on Synthroid, but just for your purposes, you can see the different forms you might see out there in the real world. Most frequently, we're going to use this for things like Hashimoto's thyroiditis, right? That's where you have the autoimmune destruction of the gland. Things like mixed edema are very kind of progressive hypothyroidism. Any patients who had a removal of the thyroid gland, that can also be useful for them as well. Okay. So again, their mechanism specifically is just they're going to be getting into any cell that has these kind of receptive genes with our binding sites within the actual nucleus of the cell. Again, they're going to be working just like any other hormone, getting down to the nucleus, activating those receptors, and then causing gene transcription to occur. To be aware of that. Sometimes you may actually see some patients, because what effect do you think that has on weight? Should decrease it, right? Because you're becoming more metabolically active, which is why you sometimes see weight gain as being a sign of hypothyroidism. Sometimes you will have patients who are trying to kind of game the system a little bit, and they're like, oh, I feel kind of sluggish lately, and I really think I could use some thyroid hormone. Really, they're trying to do it for weight loss purposes. You may see that every once in a while, but that could be one additional benefit you could have for some of your other patients, So anywho, so that's how we can replace thyroid hormone. So again, levothyroxine is going to be the main one you're going to use in that case, but again, not a fast-acting drug. On the other hand, if you have too much thyroid hormone around, how can we deal with that? And so we can use these thioamide drugs. There's two ones specifically. We have propylthiouracil, or PTU, and then we have methimazole or tapazole. So these are the main anti-thyroid drugs we're going to have out there, and these deal specifically with blocking the production of thyroid hormone, not necessarily on interfering with the active thyroid hormones already out in the bloodstream. Okay, so if you had a patient with thyroid storm, these drugs don't specifically treat that. They're not going to treat those symptoms of that. They just prevent further production of thyroid hormone. Okay. Talk about their mechanism in just a second, but as far as complications go, they're pretty well tolerated for the most part, but you may have some risk for granulocytosis, so monitoring their CBC over time will be important for those patients.
They work for Graves' disease too.
They would work for Graves' disease, yeah. Yeah, so this is one of the more common cases where you would actually use that. So anyway, with these guys, what they're going to be doing specifically is interfering with that step, the oxidation of iodides. They prevent the conversion over to iodine. So if you prevent that step, the peroxidase enzyme, you're going to prevent that the binding of that with tyrosine, and thus you're not going to be able to produce that mono and diiodotyrosine there. So basically, any amount of the hormone that's already kind of started production is going to be able to kind of get through the rest of the steps there, but it prevents that iodine from being used in that kind of first initial steps right there. Again, most frequently you see it used for things like Graves' disease, which is that autoimmune disorder reproducing kind of the antibodies that activate the thyroid hormones as well. And then also for multinodular goiters, things like that, you can actually help to shrink the tissue in order to help kind of better enhance the ability to resect it. So other ways that we can actually deal with thyroid hormone production is you can actually use iodine. One of the ways that we can actually help to ablate the tissue itself is with using radioactive iodine, right? So iodine doesn't get used a lot in the body, but when it does, it's mostly going to be in the thyroid gland. And so you can actually use radioactive iodine to get preferentially taken up into the thyroid gland, and there it can release its radioactive rays and things like that, and actually able to destroy some of that tissue. So obviously, what do you expect to see after you use radioactive iodine? So you see it shrinking of the gland, but then also what? So if you're kind of destroying all that tissue, hypothyroidism, right? Absolutely. So if you can't produce your own thyroid hormone anymore, so this is very frequently patients will have to go on. So again, this is usually for like cancer patients and things like that, but they will get put on replacement levothyroxine after they get this procedure done. So just be aware of that. Usually you can actually give oral, either solution or capsules of the radioactive iodine that gets taken up, because really iodine likes to get concentrated right there in the thyroid gland. It's not radioactive enough to give you superpowers though. So I tried that, didn't work. So be aware. Some other things you can do. So again, we mentioned that high levels of iodine can actually inhibit the process. So again, low levels will cause less thyroid hormone to be produced. Very high levels will shut down this process as well. And so this is where you can see saturated solution of potassium iodide, otherwise known as SSKI. So if you ever see SSKI, that's that supersaturated solution of potassium iodide. And then there's also Lugol solution, which is just another name for this saturated potassium iodide. So you can give that. It can be used to treat hyperthyroidism by basically just kind of shutting down that whole process by just kind of overwhelming the thyroid gland with more iodine. Not usually used as sole therapy. You may see it used in conjunction with things like methimazole or PTU potentially. And you can see some pretty rapid improvements, around a week or so, as far, which is pretty rapid, at least for the thyroid gland, as far as production of new hormone and things like that. So sometimes you'll see this being used to help kind of decrease vascularity in the size of the gland prior to surgery. So sometimes you'll see it used for that purpose as well. You can actually use it as a prophylactic against radiation exposure as well. Interestingly enough, if there was ever a nuclear fallout, one of the big problems, if you were not blown up by the bomb, one of the other problems you'd actually have is a lot of radioactive iodine actually gets produced in nuclear fallout. And so one of the things that you would have happen is you'd just kind of have natural uptake of this iodine. It would get incorporated into the gland, and then just like we saw previously, it would just basically destroy that tissue. So actually hypothyroidism would be a major concern after a nuclear bomb went off, right? So one of the things you can actually do is take prophylactic iodine to make sure your gland is kind of replete with that, and that actually will prevent the radioactive stuff from getting uptaken, and you just eliminate it otherwise, right? So for any of you conspiracy theorists out there, make sure you have lots of iodine on hand. Okay. This can also be a problem if you're using things like we mentioned with pediatric patients, especially infants. Like, what is their skin? What's the permeability of their skin to drugs like? A lot more permeable, right? So you typically do not want to use things like betadine for those patients because that'll lead to hypothyroidism, right? Because they're going to absorb too much iodine, and that can lead to them actually shutting down the thyroid gland. So that's one reason why we use things like chlorhexidine instead for those infants and things like that, right? So just things to keep in mind that they absorb drugs much better through that thin skin than an adult might. But anyway, also another thing, some contrast media actually contain iodine. It's one of the molecules you see in there, and so sometimes you can actually use this ipodate being used sometimes to treat thyroid storm. So it's not approved for this. It's kind of an off-brand use for it, but it actually helps to convert or prevent conversion from T4 to T3. So the less conversion from T4 to T3 you have, the better off you're going to be for those thyrotoxic patients. So there may be one other place you might see this being used, kind of an off-brand kind of situation. See contrast dye being given for someone who's not going to imaging, it could be it. Okay, so any questions on that section? Okay, I think I'm going to go ahead and get started with the next one just because I like you guys so much and I just want to keep talking to you. So, all right, so now we're going to discuss HIV. Also, we'll talk about some STDs, and then we'll also cover hepatitis as well, since that is a very common sexually transmitted infection as well. So, start off with HIV. What is HIV? It's a virus, yep, good. It's a human immunodeficiency virus, right? So have you guys covered any of this at all yet? Okay, so you've already started covering this. So eventually, basically, it's a retrovirus. So what does that retrovirus mean? It's like a hipster virus. It
takes parts of your DNA and then it does it backwards. Is their own DNA.
Exactly. It's able to take its own, in this case RNA, and is able to basically inject it into your own DNA and have you basically produce the new virus, right? So it was infecting you before it was cool, right? Like, I'm just kidding. Another bad hipster joke. Anyway, several varieties that are out there of HIV. There's HIV 1 and 2 primarily. Which one is most common here in the U.S.? It's 1, right? HIV-1 is more common here. That is actually important because some drugs have more or less activity based on the type of HIV you're dealing with. Now, if you went over to somewhere like Africa, what is more common there? 2 is more common there. So you actually see, like, initial drug regimens are a little different based on what type of is the more common, predominant form of the disease. So keep that in mind. Obviously, transmission happens most often through either sexual contact. So most commonly, you either have like receptive anal or vaginal transmission. Parenteral can be a big one, especially amongst like who?
drug users.
IV drug users can be a big patient population for that, and also perinatal transmission from mother to baby. Okay, we're going to talk about ways to prevent spread. We'll talk about things like post-exposure and pre-exposure prophylaxis a little bit later on, and ways we can hopefully help prevent transmission, especially when you have like serodiscordant patients, so like mother to baby, or if you have a couple that was together that one had HIV and the other did not. Basically, we're going to be depleting the immune system, leading to these opportunistic infections. So usually AIDS itself, the acquired immunodeficiency syndrome, is defined as what? And when can you say you have AIDS versus HIV? Yeah, so usually CD4 count less than 200 or
one of the AIDS-defining illnesses.
Exactly, so an AIDS-defining illness. So what are some examples of that?
Kaposi
sarcoma, PCP pneumonia. Cytomegalovirus is a good one. Mycobacterium avium complex. So a lot of different conditions that a patient who we can be exposed to day in and day out and not really have any problems with it because we have active immune systems. But once you get that CD4 count down low enough, they're really not able to mount a good defense against it. So we'll talk more about opportunistic infections a little bit later in this section as well. So anyway, so we're depleting the immune system, and so basically we're going to see that the mainstay of pharmacotherapy here, not really a lot of good non-pharmacologic therapies, unfortunately, but really we're going to be using drugs here, and so we're going to call this highly active antiretroviral therapy, or HART, or you may just see antiretroviral therapy, or ART. So either way, that's what that's referring to. Okay, and so they're going to be on a pretty potent cocktail of drugs, right? So we never just have mono treatment for HIV. They're going to be on several different drugs, working on different mechanisms in order to help prevent the virus from replicating, right? Is there any way we can completely clear it? Not currently, right? They're always working on new vaccines and things like that, but we'll see if that ever comes about. That would be pretty amazing, though. So anyway, this is a good slide. I'm very, very sorry, but there's a lot of HIV drugs that you should at least be familiar with and being able to at least identify what category they fall into, okay? This slide is good because it'll kind of give us an idea of all the different steps of the HIV replication cycle. This is also a good place to see where a lot of our different drugs are going to be working at specifically. Okay. So whether a drug is working on, say, the integration of the viral capsid with the actual cell, or whether it is working on things like the protease enzyme and preventing the production of new active proteins for the virus to use. All the different sites, and it's important to know what drugs fall into those categories. Okay, so we'll talk more about this in much detail as we go along, but you can kind of reference back to this picture here. So you have to know the life cycle of the virus in order to understand how the drugs are working specifically. So it's good to have a nice understanding of that. Basically what's happening here is that once the virus enters the body, it has a couple of different glycoproteins that have these affinity for the CD4 receptors, right? So they're targeting the CD4 expressing T cells most often. So glycoprotein 160 is really one of the more important ones there. When the binding occurs, there can be some kind of co-receptors that are also helpful for getting the virus into the cell. And so we can have things like these chemokine receptors like CCR5. And so you're going to have some patients who express CCR5 and some patients who don't express it. And that'll be important to whether or not you can use certain types of drugs, right? So we'll talk about some testing you have to do before you can even start certain drugs based on whether the patient would even respond to it, okay? So, and again, sometimes the virus will either express or not express the CCR5 chemokine receptor as well, and so you can have some issues, or eventually one drug will work for a while and then it won't work due to some mutation. It can be things like this. But once the virus is bound, it's going to have this membrane fusion, right? So we're going to see there's a way to actually inhibit that fusion. We'll talk about that enzyme a little bit later, and then the virus gets internalized. Okay. Once there, the capsid is going to uncover itself and release out the single-stranded RNA. Okay, so then the RNAs, along with some of the other proteins that the virus normally makes, it's going to start to use reverse transcriptase, which is why it's a retrovirus, to make a complementary strand of DNA, right? So instead of going from DNA to RNA like we normally do, it goes from RNA to DNA. That's the retrovirus portion of that. And then basically the reason why these are so hard to treat is because it is very error prone. It's very kind of poor at doing its job, and so lots of different mutations occur when doing this, right? Usually when you have significant enough mutations, you basically see kind of really kind of death of the cell or death of the virus, but in this case it's able to really handle a lot of different mutations and continue working. So you're going to see that treating HIV for a patient can kind of be a moving target, where you can start out with the one type of treatment and it works for a while, but then based on this reverse transcriptase and how sloppy it is, you're going to see these mutations make certain drugs not effective anymore. And so you have to constantly kind of be shifting the drugs that you're using in order to help make sure you're having active or activity against that type of virus. Okay. So then HIV reverse transcriptase can make a double-stranded DNA, right? And so again, those rapid mutations lead to for the inability for the immune system to even really target the virus as well, which makes it so difficult for us to even clear the virus in all cases. But once that DNA, that double-stranded DNA gets migrated over this nuclease, I guess migrates to the nucleus, which I spelled that incorrectly, but basically gets integrated into the host DNA by the enzyme integrase. So we're going to have certain drugs that actually block that step as well. Okay. Then at that point, what happens? You're working for the virus, right? So at that point, you're starting to produce all these new viral proteins and RNA and things like that. And then the virus is going to end up budding out from the host cell. It'll have its functional proteins made by the enzyme protease, and then it gets released off to infect another cell. Okay. So then your cells are now producing viral RNA, and there's really not a good way to reverse that process at this point. Okay, so you're starting to see some of the different sites where we can actually block production of this virus in a couple of different steps here. A lot of these things are going to either inhibit production of new DNA or RNA, or it's going to be working to block certain enzymes that the virus needs in order to help complete this process. Okay. So there's a couple of different stages of the disease here. So I'm sure you guys have learned about the kind of the three main stages, but you have an acute illness that can occur. So you can get this kind of antiretroviral syndrome or this kind of mononucleosis-like illness that occurs kind of initially. And then you kind of have this latent period that occurs for a while. The patient may not really even realize that they have any kind of virus sitting around, right? That kind of progresses onto the more chronic type of infection where they're usually is where they're starting to get the active treatment. And then finally, they get kind of the terminal AIDS, where they have either the CD4 count low enough or they get the AIDS-defining illnesses here. So what are we monitoring for? Mainly we're doing CD4 cell count and viral load, right? So what does monitoring CD4 cell count do for us?
Gives us an indication of how the patient is doing.
Right, it tells us, yeah, how progressive is the destruction of their immune system, right? So obviously the lower the CD4 cell count, the more progressive the destruction is. Conversely, if it's higher, that's a good sign, right? It means that the immune system is going to be able to function better. And the viral load is really telling us what? Just how well the virus is replicating, right? So if you have a very high viral load, you're able to detect lots of copies of the RNA and things like that. That means that the virus is able to just reproduce to its heart content and is doing its thing, right? We're going to be seeing with our drugs, what we're hoping for is to have a rise in our CD4 cell count. We're kind of taking the pressure off the immune system, and we have a reduction to undetectable levels of the viral load, right? We will not be able to detect any of that virus because that means that the virus is so suppressed that hopefully we're not having any further progression and infection of other cells in the body, okay? So those are the main things we're going to be looking at when we're doing our therapy here. Okay, so the treatment goals, obviously we want to decrease morbidity and mortality. We'd like to increase quality of life for these patients if possible, and then preserve that immune function as long as possible, right? So we'll talk about when to initiate treatment a little bit later, but you'll see that that actually has been changing over time to the point that we're at now. Do you guys know when you actually start treatment? Yeah, as soon as you get diagnosis. Nowadays, it's as soon as you get diagnosis. That wasn't always the case. We'll talk about why that wasn't just a little bit. Obviously, you want to prevent transmission from person to person. So there's lots of different efforts that are made to do that. We'll talk about pre and post-exposure prophylaxis a little bit later on. Obviously, things like safe sex and other non-pharmacological therapies are going to be some more potent ways to prevent transmission. And then we'd like to have as maximal and durable a suppression of replication as possible. So our goal is always going to be undetectable viral load. If you can measure the viral load, you're not doing your job right. So you want undetectable. Okay, and keep in mind, I'm not an AIDS expert. There are people who dedicate their entire careers to doing just this. I took a whole semester-long class on it, so you're not going to get everything in the next few hours, but just be aware this is at least a jumping-off point and at least have a basic understanding, because as our therapy has gotten better, our patients are living longer, right? And so that means they're getting other comorbid conditions. And so you're more likely to run into these patients who are on HIV therapy. You may not be seeing them for that, but it's important to realize, how their drugs are interacting with their other disease states, drug interactions, and other things like that. You want to be able to at least be somewhat cognizant of, to be like, okay, maybe I need to take that into consideration and change something about what I'm doing. So, anywho. So our approach to treatment, so ongoing replication is going to lead to further immune system damage and eventual AIDS, right? So we want to prevent that as much as we can. You mentioned that RNA loads is going to be kind of indicating how well the virus is replicating, so lower the better from that standpoint. And that CD4 count needs to be as high as we can possibly get it. So what you typically see when you start a patient like on heart therapy, especially if you caught them late and say their CD4 count was already say below 200, you would typically see viral load decrease down to undetectable, and hopefully see their CD4 cell count start to slowly kind of increase, right? CD4 count is also going to be really important for dictating when we start things like prophylaxis for certain opportunistic infections. So say for instance, once their CD4 count gets below 200, we're going to start them on Bactrim 3 times a week to prevent PCP pneumonia. Things like that. So we'll talk about those a little bit later as well. We have found that combinations of antiretroviral agents is going to lead to the best chance for suppression. So this means they need to at least be on 3 agents. We'll talk about what those regimens look like in a little bit later, but at least 3 drugs, probably 4, maybe even more potentially, depending on the type of virus they have and what type of resistance they have going on. Okay, so they're going to be on a lot of drugs. And then you're going to see that compliance is going to be really, really important, because if a patient is not compliant with their ART therapy, what's going to happen? What happens if
They're going to get AIDS.
They're going to get AIDS eventually, but what happens if I don't fully treat a bacterial infection? They become resistant. Same thing happens with the virus. So this is why compliance is so important, is because if they're not going to be compliant, they're going to get a resistant mutation, right? This can sometimes, even one mutation in some cases, can wipe out an entire class of drugs from ever being used again. And once you're resistant to those drugs, you can't use that ever again, right? So then at that point, you're dealing with a dwindling pool of available agents to actually treat these patients, right? So this is why you want to make sure they're going to be super compliant. This is why you have to make sure they can actually get the drugs that they need, right? Because the insurance coverage and things like that are going to be really important. And especially if you imagine, some of your patients, they may be homeless, they may be engaging in really high-risk behaviors like IV drug abuse. They may not be the most compliant patients to begin with, right? So in some of these cases, well, if they're not going to take it every single day like they're supposed to, there may not even be a point in them taking it at all, right? So these are big conversations you have to have, and education is so important with a lot of this stuff. Okay, so we mentioned the optimal time to start treatment has kind of been a moving target for a period of time. They used to say, we'll wait until the CD4 count gets down to 200, or wait till it gets down to 50, or wait till whatever happened to be. The idea behind that is that back in the day, because imagine when was AIDS really starting to become a big thing? In the 80s, right? So this has not been a whole lot of time that we've actually been dealing with this disease state, right? So I mean, like 30 years. So in that time, we didn't really have a lot of drugs in order to treat these patients with, and we knew that there was potential for them to become resistant, okay? So because of that, they wanted to hold off as long as possible before treating in order to help maintain activity of those drugs as long as they could, okay? Nowadays, we have lots of really good drugs that can provide really good suppression of the viral replication. We say, nope, forget that. We want to keep the immune system as strong as we can for as long as possible. So start immediately. As soon as you have a diagnosis, as soon as you can measure the levels, you want to go ahead and start treating. Okay, this helps to reduce transmission, right? Because it's a lot easier to transmit virus to somebody else if you have a really high RNA viral load count than if you had undetectable amounts, right? So that can be one way to help prevent transmission, and then you also have fewer AIDS-related events. Okay, so it's all good things for our patients. Okay, so here are the main groups of drugs that we're going to be being used here. So we're going to have drugs that are integrase inhibitors. So you might see these being used as INSTIs. These are the integrase inhibitors. We're going to have nucleoside or nucleotide reverse transcriptase inhibitors. So these are going to be our NRTIs. We frequently be called that. And then we're going to have non-nucleoside reverse transcriptase inhibitors, which would be our NNRTIs. So keep in mind there's a big difference between the NRTIs and the NNRTIs. We'll talk about what those are a little bit later. And then you have also some enzymes to help inhibit the protease enzyme, the fusion enzyme, and then also these co-receptor inhibitors. So lots of different classes here. And back in the day, like back in the 80s, we had like maybe one drug to use, like lamivudine, I think was like the first one we had. And so nowadays we have much better treatment options for these patients. We've done lots of trials to figure out exactly what type of regimens they should be on in order to help get that maximal suppression of the viral replication, right? So this is how we kind of came about to say, okay, you need to at least be on this 3-drug regimen and what those drugs should be. So we'll talk about that in detail as we go on from here. So I think I will probably go ahead and cut it here, and then we'll come back and continue on Tuesday. Any questions? All right, I'll see you guys Tuesday.